people came, and it was decided that we should form an international society, and that was the beginning of it. The first meeting was in Delhi. But since then, I think we have about 40 plus countries that are the members, some of them less developed than others. I mean, Baku is probably the biggest political force in medicine here in terms of bringing about change for ethnic minority doctors.
So how many pediatricians do we have on this CAPIO group?
In fact, there are more pediatricians because Anupam's a pediatrician, I'm a pediatrician. As Mata, who's the president of the BAPIO, is a pediatrician. The first American one was a pediatrician. So in fact, they're rather quite, more pediatricians than others. They're quite a lot of cardiology. It's quite a big organization now. And the membership actually numbers belie how big it is. Because each time we have a meeting in a country, there are loads of people from that country who join. Anyway, I think I'm taking too much time.
So, yeah.
And I'm on the executive as well. And we need a few more women on the executive.
So do you hold conferences internationally on this?
Yeah. Well, with COVID, it's all gone a bit astray. But before, the winter meeting was always in India around about January, February. And then the middle meeting was in another country. So we've had them in Canada, had them in Russia, UK, a number of places really. So it hasn't quite got that footing yet, but hopefully it will.
Thanks.
Yeah, no, I'm just seeing a message before. Oh, sorry. Shouldn't really be coming up again.
Is there a meeting in 2023 in India?
There's a meeting in February. I can't remember the date, but in February.
11th and 12th February, Ahmedabad. 11th and 12th February.
Yeah.
That's the IPA meeting, right?
No, that's the GAPIO meeting. But API, they decided to go separate, really, rather than have a joint meeting, because API, so many people come. Slightly different function. But it's also not just a clinical meeting, it is really...
I think the IPA as well is in Gandhinagar this year, next year.
But the idea is to try and influence the government, bring about change, and basically to work together to learn both ways from each other.
Yeah, this time IP is in Mahatma Gandhi Nagar, this Ahmedabad, from 19th February to 23rd February. And both our 60th Pedicon IPA and this IPA, International Pediatric Association, they are doing together.
So it's 7 o'clock. Should we start?
Yes, sir. Yes, sir.
Yeah. Okay. So, namaste, everyone. Good morning, good evening, or good afternoon as per the local time. I'm Dr. Sushil Jain. I'm the Honorary Advisor of CAPIO. And I'm really pleased to conduct this session along with the Indian Academy of Pediatrics on pediatric inflammatory bowel disease. Dr. Nida Mirza would be the moderator for this event, and she is a pediatric gastroenterologist at our hospital at Apollo Hospital, Indore, MP, India. I'll request Dr. Nida to take over, please. Thank you.
Thank you, sir. Good evening, everyone. Myself, Dr. Nida Mirza. I'm consultant pediatric gastroenterologist and hepatologist at Apollo Hospitals, Indore. Today, we are all joined here for an academic session on pediatric inflammatory bowel disease. It is organized by GAPIO in collaboration with IFP. So I will be the moderator of the session, and Dr. Bhupinder Sandhu will be the chairperson of the session. And I would like to introduce Dr. Bhupinder Sandhu. She is a pediatric gastroenterologist with 25 years of experience, and she was the responsible person for starting the pediatric gastroenterology and nutrition unit at Bristol Royal Hospital. She has been awarded the 3rd highest civilian award in the UK, and that is award of the British Omega Society. And she is also the executive committee member of the GAPIO and also the Women's Forum GAPIO member. Now I would like to invite Dr. Bhupinder Sandhu to introduce our speakers.
Okay, thank you very much, Dr. Mirza, for this very generous introduction. By the way, OBE is a bit like the Bush, the presidential awards you get from the in India. It's called an OBE. Anyway, I'd like to thank the Indian Academy of Pediatrics and GAPIO leadership for running these highly successful seminars. They started during COVID and have continued and brought together really leaders in the field from around the world. And the one advantage is, we using Zoom from the COVID days, is that we can continue these without very little expense. And it is great to have people who are, pretty leadership material in their field to be able to give these seminars. And I've done a few of these, and sometimes we've had over 1,000 participants. It varies a bit really, but on the field. And I'd like to thank particularly the leadership, which is president of the Indian Academy of Pediatrics. The one who started it was Bakul Parikh, and the current president, Ramesh Kumar, and then Anupam Sibal, who's our president of GAPIO, and the whole team at GAPIO, including Dr. Jain and Dr. Malik. Thank you for inviting me. And today's subject is inflammatory bowel disease, which is a subject quite dear to my heart. When I was appointed as a consultant to set up the department, which is now quite a big department, there was hardly any IBD. In fact, my interest was oral rehydration and acute diarrhea, but we started seeing lots of cases. So we then did a national survey to see what the instance was. And that was, it was just increasing all around Europe. So we set up the European Society of Pediatric Gastroenterology IBD group, more now known as a Porter group, which has been very instrumental in making the field, like we provide the first agreed way to how to diagnose and how to treat, and it gets modified every year, and that has international standing. At the time, I was really sort of very friends with Neelam Mohan, who's the president of the gastro chapter of Indian Academy of Pediatrics, and we encouraged you to set up an Indian pediatric gastroenterology chapter, and I was at the first meeting. And at the time, people thought IB didn't exist in India, but that's no longer the case. And particularly in North India, the incidence is probably the same as it is in Europe. Anyway, we'll leave it at that. We've got two excellent speakers, and it's my real privilege to introduce our first speaker, Dr. Anupama Chawla, who's going to talk to us about biologics in pediatric IBD. And Dr. Anupama graduated from Lady Hardinge Medical School in New Delhi and completed her postgraduate studies in England, and got a diploma DCH from the Royal College of Surgeons, Royal College of Physicians in Glasgow. She completed her residency in pediatrics at Stony Brook University Hospital and a postgraduate fellowship in pediatric gastroenterology at North Shore University Hospital, New York. She's a board certified pediatrician and pediatric gastroenterologist and nutritionist. She's director of pediatrics, gastroenterology and nutrition at Stony Brook University Hospital, and she's actively involved in clinical research. I would like to ask Dr. Anupama Chawla to kindly please deliver your talk on biologics in IBD. And for the audience, do send your questions in as we're going along, so then we can deal with them at the end. Dr. Anupama, you have 20 minutes. Thank you.
Good morning from my time and whatever country we are in. It's such a pleasure to see everybody. Thank you, Bhupinder, for that introduction. And I had to cut this talk to just biologics in order to do justice to at least one of the two topics. Nutrition and biologics was a little much for 20 minutes. So I'm going to talk about IBD treatment as it stands in 2020. And this is really the biologic era. 1 second, my screen is being hidden by, okay. So the goals of today's talk is going to be to understand what really are biologics. The word gets thrown around a lot. Understand the current treatment trends, the modalities available and the goals of therapy, and what should we expect in the future. So goals of IBD therapy really used to be the first 4 bullet points. We used to aim for prolonged steroid-free remission. We used to want to decrease symptoms and the activity index. And we always accepted some symptoms as long as patients were functional. And improvement in the inflammatory markers, which we as clinicians love to follow, and avoidance of any medication side effects. However, the goals have now significantly become more global and long-term. Quality of life is absolutely paramount. There are patients of mine now who are in every single field, from the most active field to top of their profession, irrespective of the number of physical activities required. And the main thing that has changed is that with biologics, our goal is mucosal healing. And this, I hope, in the long run will result in significantly less side effects. And additional goals in children, of course, are growth and nutrition, which we as pediatricians, pediatric gastroenterologists, do an extremely good job about. So the medications are almost similar to Crohn's and UC. There'll be some differences, but I'm going to just talk about them together. The classes are aminosalicylates, corticosteroids, modulators, antibiotics. And today's talk is going to be more focused on biologics and some brand new Janus kinase inhibitors. So the timeline for medication really started as long ago as 100 years. And as you can see from this table, in 1930, aminosalicylates became available. Took us another 20 years for us to think of steroids as a treatment, and took us another 20, 30 years for 6-mercaptopurine to become the field breaker. And this, I'm very proud to say, was my associates, Dr. Markowitz, and our group that was paramount in doing this study. And then it took 1998 when infliximab became available, and all these red ones are the biologics. And then we quickly from there went into newer medications, almost a couple of years. And like you can see, pre-biologic era and now the biologic era. And these medications are just multiplying as we speak. So these are the red ones, are the ones I'm going to concentrate on today in my talk. And I think this is going to get even more clustered. Those 30-year gaps are way behind us. So why did 6-MP get dethroned? And this is important, and I wanted to put this right at the beginning because this is a side effect that most often scares people, mainly because of hepatosplenic T-cell lymphoma. Prior to case reports of HSTLC, TCL, concomitant therapy, thiopurine and anti-TNF was standard of therapy. There were improved drug levels, there were fewer allergic reactions, and there was less loss of response with this combination. However, since the cases of HSTCL came on, monotherapy has become much more common. The clinical presentation of this is something which must require us to do lab work as well as frequent examinations. It's a rare type of non-Hodgkin's lymphoma. It affects primarily young males. The signs and symptoms are abdominal pain, mainly hepatosplenomegaly and jaundice. Cytopenias and abnormal LFTs should be the red flag to make you think about this. Unlike other lymphomas, they're not typically associated with swollen lymph nodes, so don't get fooled. Prognosis is extremely poor, and almost 62 cases have been reported up to 2017. Most were Crohn's. 83% of them were males, and majority of them, almost 85% of them, all had concomitant therapy. And the average age was 28, and this is the terrible slide where nearly all died at the median age of 5 months. So what are biologics and how have these come to be? So a definition of really a biologic agent is that it is a protein, usually an immunoglobulin, derived from a living organism, which may be used to treat the disease. It can be manipulated to bind to other proteins, for example, TNF, and it can be mass produced. So we don't have to rely on donors, it can be mass produced, and this is why it's available so readily. Induction and monitoring on biologic therapy can vary from center to center. I put in some of my, as we do it at our center and most of the centers in the United States, it might not be standard around the world. All patients are consented by their guardians, and all children over the age of 12 give their assent prior to treatment. Screening labs are obtained. Time permitting, all live vaccinations are brought up to date. This is not always permitted by the severity of their disease. Drug levels and antibodies are obtained usually after 3 to 4 doses to determine need to decrease interval, increase dosage, or to add an immunomodulator like methotrexate to decrease antibody formation. Some of the pre-biologic screening labs that we do primarily for immunity and infection screen are EBV serology, varicella, hepatitis A, B, mumps, measles, rubella, and we also screen for tuberculosis. So these are the biologics that are being used in pediatrics at the moment. Infliximab, which is the most commonly used, adalimumab, which is Humira, and then Tisabri, Cimzia, vedolizumab, ustekinumab, and now JK pathway inhibitors have also come to be. So what is TNF alpha before we go to attacking it? It is a pro-inflammatory cytokine believed to be involved in the pathogenesis of IBD. It is known to stimulate production of other pro-inflammatory cytokines, so it cascades into other inflammation cytokines as well. It is present in excess in intestinal mucosa of Crohn's patients. It's produced by activated macrophages and Th1 cells. It is the target of several biologic agents being used today. Infliximab itself is a chimeric, which means that it contains more than just the human species, more than one species. It has a combination of a human and mouse antibody. It binds to TNF alpha. It's given every 2 months as a maintenance dose after the initial induction phase. And there's over 20 years of experience. It is one of the 2 biologic agents that FDA has approved for pediatric use in the United States. Infliximab was studied in children at a REACH trial, and in this study, it was an open label study in children with moderate to severe Crohn's disease and who were still in moderate to severe disease despite immunomodulator therapy. All patients received 5 milligrams at weeks 0, 2, and 6, and the responders were then divided into either every 8 weeks or every 12 weeks. And if you look at the table or the graph really on the right side, you'll see that the response with every 8-week infusion was significantly better than when the infusion was given every 12 weeks. The side effects are more commonly we see fever, chills, myalgia, sometimes backache, headaches, dizziness, and some nausea. Allergic reactions are more common with Remicade, probably because of its chimeric nature, urticaria, dyspnea, and rarely, very rarely, anaphylaxis. We often treat our patients, pre-treat our patients with hydrocortisone or diphenhydramine prior to these infusions. We don't want to shelf this phenomenal medication because of allergic reaction at the time of infusion. Rarely cardiovascular events occur, or tuberculosis or other fungal infections, and also hepatosplenic T-cell lymphoma, as you saw in the slide before, has been reported even without concomitant therapy. Adalimumab, Humira, is also an anti-TNF alpha. It is fully human. There is no mouse component. Therefore, it has fewer allergic reactions, although psoriasis is pretty common in this with this medication, which is not an allergic reaction, but more of an autoimmune. There is less resistance. It is administered subcutaneously every 2 weeks, and it is can be self-administered by patients. This is also FDA approved for Crohn's and UC in both adults and children. There was a clinical trial on this. This was an adult trial, and there was a 36% remission rate, 58% response rate, and at week 56, there was 36% remission rate and 43% response rate at that point. There was a study in children, clinical trial, pediatric trial. This was an open label induction followed by double-blinded randomization. 192 patients with pediatric Crohn's disease were studied in this. They were divided into either the high dose group, which was 40 milligrams, or into the low dose group, which was 20 milligrams induction followed by 10 milligrams every 2 weeks. Clinical remission, which was described at PCDAI score, which is Pediatric Crohn's Disease Activity Index of less than 10, at week 26 was considered as the primary endpoint. And the results were pretty comparable to the adult data. At week 26, there was all about 40% response with the remission in the high dose group and about 30% in the low dose group in remission. Cimzia is something that is available to us. I have not had good response myself with this medication. The advantage is that it is pegylated. It's also an anti-TNF. It's also fully humanized, and it can be given every 4 weeks dosing, but side effects are very similar to Remicade. And I wish I could tell you why the response rate for me and our group and other centers I discussed with is much poorer than Remicade and Humira. So from these anti-TNF, then we have the integrins that need to be attacked rather than just the TNF alpha. What are integrins? These are surface proteins present on lymphocytes. They are involved in trafficking of WBCs to the inflammatory sites. Integrins bind to receptors on the endothelial cells of intestinal venules, mainly in the endothelial cells of the intestine. It is MADCAM1. Anti-integrin therapy blocks the action of integrin on the surface of circulating immune cells and endothelial cell adhesion molecules, thereby inhibiting the interactions between leukocytes and intestinal blood vessels. The advantage was thought to be that these medications have a much broader action as they work on cellular level rather than just a single cytokine, and the jury is still out. Initially, this came out as Tisabri. This is a natazilumab. It is a non-selective anti-integrin. The only reason I put this here is to say from here how we have segued into more specific anti-integrin therapy. These block adhesion ability of WBCs, thus curtailing the inflammatory response. Initially, it was approved by multiple sclerosis. Now it's available for limited use in Crohn's patient. The side effects that really put this medication out of favor was progressive multifocal leukoencephalopathy, which is a disease of the white matter of the brain caused by a virus, likely the activation of JC virus. All were on concomitant immunomodulator therapy. This medication was voluntarily suspended, so as was the study. And there has been a limited release since then, since 2007, with no concomitant immunomodulator. So how to safely derive the benefit of anti-integrin therapy then? Either we could test these patients for the latent JC virus, and if negative, only then proceed with Tisabri, or we should go ahead and develop selective anti-integrin therapy, which only attacks either the alpha-4 beta-7, which binds to the MADCAM on the gut endothelial tissue. This has brought us to an anti-integrin therapy that has become extremely popular or is becoming extremely popular, called Entyvio or vedolizumab. It is a selective anti-integrin that targets WBCs headed for the gut. You can even follow this on the cartoon or with my bullet points. Humanized monoclonal antibodies specifically against alpha-4 and beta-7 integrins, and Entyvio binding blocks this site to blocks the adherence of this integrin alpha-4 beta-7 binding to the MADCAM1. It does not affect lymphocyte trafficking to the brain, and there is no evidence of it causing PML. This is a huge advantage, but obviously it's not the drug for multiple sclerosis. Then it is a drug for us, for our patients with inflammatory bowel disease. And no medication was detected in the CSF of healthy volunteers. This was a study where the maintenance was studied 373 responders of 521 open label patients at 1 year. Out of these, 45% were in clinical remission, 14% of the placebo had a remission rate, 37% of the patients had been on a previous anti-TNF therapy. So till when these studies were done, majority of the patients had been on anti-TNF therapy. However, this is not the case anymore, and patients are going straight to vedolizumab treatment. This was a study in Crohn's disease. 185 patients with active Crohn's on these medications were studied. At 2 months, there was almost a 50% response rate and 30 to 37% remission rate. So a medication that is available to us either in naive biologic patients or in patients who have not responded to anti-TNF. Ustekinumab, which is an anti-P40, has become available. There are two component cytokines. IL-12 is a key cytokine that drives inflammatory response. It is found in high concentrations in Crohn's disease. IL-23 promotes T-cell response, also found in high concentrations in the CD Crohn's disease patients. IL-12 and IL-23 share a common subunit P40, which is targeted by the ustekinumab, which is also easily called Stelara until it becomes non-patented. Ustekinumab for ulcerative colitis has been studied as well. There are two arms here. These patients were with moderate to severe UC were taken. They are given an induction dose, which is given intravenously, either by a set dose of 130 milligrams or 6 milligrams per kilogram. There was a placebo group in this also. And at 44 weeks, almost 40% of the patients who had been receiving the ustekinumab at every 12 weeks had responded, and almost 44% who had been receiving it every 8 weeks had responded. So this is another medication that we are using more for our Crohn's patients than for, but most of the time we are using it, it is mainly in patients who have failed anti-TNF. The safety profile is pretty similar to the other medications. We have not reported any HSTLC-CL patients. However, non-melanoma skin cancer has been reported in an extremely small subgroup. Most of the side effects, which are almost in 50%, are what we see in other biologics, is sore throat, runny nose, upper respiratory infections, and redness at the site of the infection. This medication is given by intravenous dosage for the first time, and then it is given by subcutaneously every 8 weeks thereafter. So that's a huge advantage. It gives patients freedom from coming to the centers. I just found
you've got 5 minutes left.
Okay. This is a new medication that is coming up, which is Xeljanz. And this is a medication where I thought this was very nice way of presenting it. Everything is intravenous, everything is sub-Q. And here they are trying to project that the main advantage is that it is a needle-less preparation. It is a Janus kinase inhibitor. It is FDA approved in the adult patients, and we have to get significant approval to use it in children if we need to. This is the pathway that occurs. This JK pathway is involved in the activation of signaling cascades, and the cytokines Many of the cytokines are produced by this pathway. These attach to the receptor, which then trigger the JAK inside the cell. This produces the STAT protein, which then moves into the intranuclear pathway. And this, by genetic changes, will actually produce an extremely high cytokine production. And tofa or Xeljanz, as we'll call it, this attacks to the JAK pathway and significantly inhibits the production of cytokine production. The primary endpoint was remission. This was a very strict endpoint. They studied it with no rectal bleeding at all, and they wanted a score of 0, and these are the response rates. And when they were endpoint at 52 weeks was much more impressive. And this is, remember, an oral medication. Since 6-mercaptopurine, we have not had an oral medication available to us. So I just wanted to spend a couple of slides on what have we learned from the era of biologics. I could go on and on about those studies, but my slides are available to anybody who wants them. Biologic agents are extremely effective at controlling inflammatory bowel disease. They avoid hospitalization, they avoid surgery, they avoid steroid dependency, they promote remission, and they improve the quality of life. The benefits far outweigh risks. And those of us who have graduated from the steroid 6-MP era to the biologic era were skeptics, including myself. But after treating these patients for over 15 years and 20 years now, I wish these medications had been available to some of the patients who had to tolerate suboptimal life, quality of life. And now many of us even advocate this before any of the immunomodulators are tried. So which is the best drug? Cannot tell you. There are no head-to-head comparisons. It's one failure leads to the other, or so it's a judgment thing. I personally do go with anti-TNF as the first therapy, and Remicade is my go-to medication. Inclusion and exclusion criteria may have varied, and there's no head-to-head, so I wish I could recommend one over the other, but I cannot. So this is what I want you to see, the last few 2 to 3 slides. This is the natural history of Crohn's disease. And as you can see, it's 80% inflammatory in the initial stages, and this decreases significantly as your disease progresses. So we really need to use these medications in the inflammatory phase and not start using them once our patients are obstructed with strictures and not doing well. So this is not the time to use it, and I would urge you to consider early medication. Why save your anti-inflammatory for the late stage is the thing. I have even taken out this a pyramid that looks the other way, because I myself have been converted, and after seeing how well my patients do and how my fellows and trainees never see these patients in the hospital, I wouldn't say never, but not the way I did during my training, where I had 5-6 patients constantly admitted to the hospital. So early aggressive approach is definitely the way to go in moderate to severe disease, not in mild to early moderate disease, but moderate to severe disease. That would be my recommendation. The future, of course, we need to do this work. We need more genetic markers. We need to better categorize these patients so that you can say this is a TNF responder, this is a JK responder, or this is an Entyvio responder, integrin. We don't have that ability right now, but people are working on that aggressively. We should be able to recognize a patient for the treatment based on their cytokine, genetic, or phenotypic profiles. And like I said, consider aggressive treatment before they become fibrostenotic or penetrating. Can hypothesize that TNF non-responders have a different disease than TNF responders, catch it early. And maybe this is just me, but I feel our intestines just have a final way of presenting itself. And there are several diseases which all get lumped together as either Crohn's or UC. each type should be really recognized, and maybe we'll have a lot more phenotype and our treatment will be driven by their profile. Targeted therapy would be the best way to, if we could identify patients, and please start early treatment if available. How did I do for time, Bhupinder?
Well, you're slightly over, but you're such a good speaker. It's fine.
Yeah,
So is that it?
sorry about that. That's why I had to
Very-
take nutrition
yeah,
out,
very-
because I could talk on nutrition forever also, but I couldn't do justice to either. Thank you so much. I'll stop.
Well, thank you very much, Dr. Anupama, for a very informative and comprehensive talk. We're now going to move on to our next speaker. And the next speaker is a bit more local than coming from New York. Dr. Monak-san Sharma is going to deliver a talk on pediatric IBD 360-degree overview. Now, a little bit about his biography. He's an associate professor of pediatric gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Could you turn off, Dr. Anupama, could you turn off your slide share?
I thought I did. I did not.
It's still on, thank you.
I'm sorry.
I think we are seeing the screen of Dr. Moinak.
No, I'm seeing Dr.
Oh yeah,
Sen
sorry,
Sharma.
come on, sorry. Okay, thank you. Yeah, that's come on. That's lovely. Thank you very much. And so he's at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow. He's published 67 research articles and 31 book chapters. He's been conferred with nearly as many awards, 42 scientific awards, including R.K. Sarma Award, Professor S.S. Agarwal Award, Best Award by his institute for a research presentation, Sir Naik Award from Indian Society of Gastroenterology, and Young Investigator Travel Award by European Society of Pediatric Gastroenterology, and Asia Pacific Association for Study of the Liver. He has served on the executive of the Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition. Dr. Monak, I now kindly invite you to please deliver your talk on pediatric IBD 360 degrees overview.
Thank you, Dr. Sandhu. Am I clearly audible?
Yes.
Yeah, so 360 degrees in 20 minutes, it's quite a bit of a challenge. I feel I'm reminded of Keanu Reeves in Speed, who was trying to defuse the bomb in 20 minutes. What is IBD? It's a chronic inflammatory condition of the GIT. It affects all ages from neonates to elderly age group. And if you have a mucosal disease, it's going to be an ulcerative disease. If the muscles are involved, it's going to be stricturizing. And if you have all the layers involved, it's probably going to result in a fistula. It can involve the large and or the small bowel and or the upper GIT. There are extraintestinal manifestations occasionally. Most would respond to immunosuppression or immunomodulation, but proportion might require surgery in the long run. So how do we understand the pathophysiology? It's very, very complex. We don't know exactly why, but there is a link between environment and the microbiome, and possibly a lot to do with the genetic makeup of the individual. And obviously there will be issues with the even impaired epithelial barrier of the intestine, and one would probably synergistically overwhelm the other. If you look at the age-based pediatric classification, you have the pediatric IBD has been divided into many smaller parts, the 10 to 17, 6 to 10, 2 to 6, less than 2, and then the neonatal IBD. And less than 2 years is a monogenic IBD. It's usually associated with a congenital immunodeficiency. It's a horrible entity to treat, especially in India, because these children basically have nothing left, and they're almost always on immunomodulators. Polygenic variety is the one that is most similar to the adults. If you look at the disease entity by its classification, then you have ulcerative colitis on one end, where you only have the colonic involvement, which can be atypical or typical. Or you could have the Crohn's disease, which is colonic, maybe panenteric. In fact, you could have the small bowel and the upper GI. And here you have Crohn's colitis and Crohn's disease. Crohn's colitis is only limited to the colon. And then you have an in-between category that is the IBD unclassified, which may either progress to UC or Crohn's disease, depending on how it moves with time. And the accuracy to differentiate between these two entities, UC versus Crohn's or Crohn's versus UC, is at best 80%. So essentially, Crohn's disease is basically a transmural inflammation. So patches of the bowel get affected. Possibly it is pediatric in many of the situations. And ulcerative colitis, on the other hand, is a very superficial involvement, and it usually is limited to the colon. As Dr. Sandhu had elegantly said in the first part of the introduction, that it's increasing across Europe and probably double the rate in the last decade in the adolescents. And what we're seeing in developing countries such as India, and this is data from my own institute, it is exploding. We've had 3 times the amount of IBD we've diagnosed in the last 5 years. So it's like a pandemic of its own. When you look at the pediatric IBD and you compare, you will see that those in Europe, about 25% of the entire IBD is contributed by children. The mean age is about 10 years. Most commonly, it's Crohn's disease. In India, it's just 10% of the entire IBD population, but this number is growing. And again, our mean age group is also very similar, it's about 10 years. When you suspect, when a patient comes with abdominal pain, diarrhea, hematochezia, these are the essential 3 features that diagnose IBD, but the proportion of hematochezia is higher with ulcerative colitis than with diarrhea. And this is a very elegant paper which we've always been citing for years together. This is Dr. Sandhu's paper, where a lot of patients of IBD have been analyzed in the UK. And the classical triad of pain, diarrhea, and weight loss in Crohn's is only limited to 25%. So if you look at the age group with time, you would see that those with Crohn's disease have more of diarrhea and abdominal pain. Abdominal pain is a very, very important sign that tells you there's a transmural inflammation going on, less of rectal bleeding. But when you look at ulcerative colitis across all age groups, the rectal bleeding is the most important part of its clinical manifestation, not so much of abdominal pain and quite a bit amount of extraintestinal manifestation. Growth failure in children is very important. Reduced height velocity may be the first clue. Delayed bone age, delayed puberty. When you look at the disease distribution, ulcerative colitis, you can have limited to the left, to the rectum. You can have it all the way up to the left side, that means splenic flexure, or you can have a pancolitis, that means the entire colon is probably involved. Vis-a-vis Crohn's disease, where you have an ileocolonic disease, sometimes you may have only isolated colonic involvement, or you may have a panenteric, that means a small bowel and the upper GI are also involved. And very importantly, there may be a perianal disease in which you might be using the TNF-alpha agents, anti-TNF-alpha. This is again from Dr. Sandhu's very well-cited paper. In contrast to adults who say there is rectal sparing in Crohn's disease, we see, and this paper has also shown that about 40% of Crohn's disease in children have rectal involvement. When you look at the disease extent and behavior, then as I have told you, Crohn's disease can be classified based on age, location. Then you have in behavior, you have non-structurizing, structurizing, penetrating, or a perianal disease. And ulcerative colitis can be either severe or not very severe, and depending on how much the disease extent is. Extraintestinal manifestations, you have joints, you have the skin and the oral cavity, you have the eyes. These are the most common extraintestinal manifestations. And joints, mostly they are non-deforming arthritis. You can have sacroiliitis. And in skin, usually the oral ulcers. In eye, you have the uveitis. It's a bit rare to find liver, but primary sclerosing cholangitis is well associated with ulcerative colitis. Bones, coagulation, and kidney, these are the other extra intestinal manifestations. So when you look at these intestinal manifestations with time, you would see that they may occur before the diagnosis of IBD is made, or at the time of IBD diagnosis, or well after when the patient is probably even in remission, some of these extraintestinal manifestations may just crop up, because in totality, it's an immunological phenomenon. How would you investigate? When you have anemia, thrombocytosis, or a high CRP or ESR with a low albumin, about 2/3 of all IBDs have this combination, and it raises the suspicion for IBD. And the ancillary markers such as P-ANCA and ASCA, they just adjunct to the diagnosis of IBD. They really don't don't help much, but they are important in IBD unclassified because it tells you which side you might be further going in future. When you want a diagnosis, you want a colonoscopy for sure with ileal intubation, multiple biopsies from the disease sites, upper GI, and with the biopsies, small bowel imaging, MRI of the pelvis if you have a fistula, capsule endoscopy if you don't have a stricture, and an enteroscopy, which may be challenging in children. Look at the endoscopic pictures. Essentially, ulcerative colitis is a mucosal disease, so you're going to have a superficial ulcer. And Crohn's disease has transmural involvement, so you're going to have a deep ulcer. But what happens is, our problem in India is we have tuberculosis that mimics IBD, and because tuberculosis causes endoarthritis, you may have deep ulcers. So Crohn's and tuberculosis may be very differentiate. These are small superficial ulcers in ulcerative colitis. These are the ascites. These are serpiginous linear deep ulcers that are seen with the Crohn's disease most of the time. These are bear claw ulcers that are again seen with Crohn's disease. Circumferential ulcers, they were earlier thought to be pathognomonic for tuberculosis, but they're seen in Crohn's disease too. There is a diffuse involvement when you have ulcerative colitis, and you have sharp transitions in the mucosa between normal and abnormal in ulcerative colitis, very rare with Crohn's. Pseudopolyps are not discriminatory between the two conditions, but these are mounds of regenerating epithelium that is there in the colon. And between the ulcers, you may have elevated mounds of mucosa, and these are called cobblestoning, very commonly seen with Crohn's disease, but also seen in ulcerative colitis. If you have a destroyed IC valve, it's either going to be Crohn's or tuberculosis. Ulcerative colitis just causes backwash ileitis. It never destroys the IC valve. Internal fistula, never ulcerative colitis. Almost always it's going to be Crohn's or tuberculosis. Perianal disease, again, very common with Crohn's and tuberculosis, not so common with ulcerative colitis. Biopsies are a must from all segments of the colon, and you must take biopsies from the involved and uninvolved areas to map how far the disease has gone. Ileal biopsies are very important for Crohn's disease if you find ileal ulcers, and upper GI biopsies are also very, very important for Crohn's disease. You must take it from the second part of duodenum, antrum, body, and its face. Always, always, always tuberculosis for developing countries, not so much probably for the developed countries. You must look for evidence elsewhere: pulmonary involvement, caseating lymphadenopathy, MAN2, contact histories, granulomas. Look at the granulomas on the biopsy very carefully. Are they caseating? If they are, then most likely it's tuberculosis. If they're non-caseating, they may suggest Crohn's disease, but you can have non-caseating granulomas also in tuberculosis. Very important, when you take the colonic tissue sample, you must send for gen expert, and you will get a turnaround time within 8 hours. You'll be able to make out whether there is tuberculosis or not. This tissue also needs to be sent for culture and ZN stain. Is this Crohn's or tuberculosis? Both these pictures you can see in the above picture, both have granulomas, and in the below picture, both have deep ulcers. So which one's tuberculosis, which one's Crohn's? Well, this turned out to be Crohn's, and this turned out to be tuberculosis. So they may look exactly similar to each other. So the workup for tuberculosis becomes very important. How would you differentiate Crohn's versus tuberculosis? It's very, they have a lot of overlap, but growth failure is less with ulcerative colitis, more with Crohn's. But in India, all IBDs have growth failure. The histopathology is the one that actually distinguishes the two. The histopathology usually is ill-defined granulomas. In Crohn's, you don't see that in tuberculosis. And in endoscopy, you see a superficial involvement in ulcerative colitis with the ileal sparing and rectal involvement. not so much with Crohn's disease, where you have skip lesions and maybe fistulae formations. These are two indices, which is the pediatric ulcerative colitis index and pediatric Crohn's disease activity index. And these two are two different indices that are used for monitoring purposes. And it's very volatile. You need to go back to it each time you see a patient. How do we manage? We have the drugs. We have sulfasalazine, prednisolone, and azathioprine as the first line therapy. And on the second line therapy, we have methotrexate, cyclosporine, tacrolimus, biological agents, and thalidomide. The problem with India is that, as compared to what Dr. Chawla had spoken to you, we can't do the top-down therapy in India. The anti-TNF agents are unaffordable, and our patients don't have medical insurance. So what we're left with is a gradual step-up escalating therapy where you use 5 ASAs in mild disease, and when you have a moderate UC, you use corticosteroids. Then you work your way upwards with azathioprine, and then you consider the biologicals. And finally, if nothing works, then maybe colectomy if it's a very severe disease. If you have a Crohn's disease, once again, the anti-TNF agents are very difficult in India. So again, you work your way up. You may use the exclusive enteral nutrition to spare the steroids, but if you have failure to that, you have to use corticosteroids. You taper the corticosteroids over 10 weeks, and you start in the very beginning only azathioprine. If it fails, you can use methotrexate, then consider biologicals, and then the higher kind of biologicals, which Dr. Chawla had shown. So the top-down therapy in India is very, very challenging, very, very difficult for patients. What's the natural history going to be like? So these are very elegant long-term studies which show that the periannual disease in children rises from 9 to 27% over 6 years of median follow-up. And that's an astounding level of increase. And that means this disease is going to worsen with time. So when you compare this with the adults, then the stricturizing and penetrating disease, which Dr. Chawla had also shown, will increase with time. So you need to catch these patients much earlier in their inflammatory stages. There are some surgical indications for IBD. You have toxic megacolon or colonic perforation. Toxic megacolon is basically the entire colonic colon has dilated by 40 millimeters in children, 60 millimeters in children, and this is an acute condition. Or you may have an acute severe ulcerative colitis that is resistant to rescue therapy. Non-responsive fibrotic small bowel strictures in Crohn's, steroid-dependent active diseases when medical therapy has been exhausted. You've used everything, but you have nothing left, then you might want to use surgery. You might do a surgery. Life-threatening colonic hemorrhage, severe growth retardation, and very occasionally colonic dysplasia. Now, we want to avoid surgery in a girl child always. And when the studies in the past have shown, and when they've done a proctocolectomy and they've done a pouch anastomosis, vis-a-vis those without a pouch, they've shown that with time, 50% of the girls are not able to conceive. So fecundity becomes a major issue. You must take consent from these children before you perform a pouch surgery. And the reason for this is probably you're going to scar the fallopian tubes when you descend deep into the pelvis. When you look at the medical therapy exposure in Crohn's disease, in 10 years' time, almost 85% of pediatric population have received steroids. A good proportion have received immunomodulators, and a large proportion, that is about 25%, have received infliximab. And these are very, very aggressive diseases. With time, over time, in 10 years' time, a huge proportion of Crohn's disease may require a colectomy or a small bowel resection. And these rates are very, very similar to what is there in adults. When you look at the timeline exposure for ulcerative colitis, you would see that a large proportion requires steroids. 25% require about azathioprine, that is immunomodulators, and a very small proportion require infliximab or anti-TNF agents, but this use is becoming more and more common. It's the usage of anti-TNF alpha is increasing, especially in the West, in ulcerative colitis. The cumulative surgery in ulcerative colitis, there's a higher colectomy rates in children as the years pass by. So it's about 20% almost in some of the older studies at 5 years of age, after 5 years after diagnosis. And colorectal cancer in ulcerative colitis is a huge threat. And in 30 years' time from the diagnosis, the incidence of colorectal cancer in adults is about 18%. And the risk factors there are longer disease duration, extensive disease, and a younger onset. And as Dr.
Sorry, your time's nearly run out. So if you,
okay, sure, I've done. Yeah,
brilliant.
And you have hepatosplenic lymphoma with infliximab and azathioprine. These are the issues in children. You have bone density and linear growth, nutrition, immunization, puberty issues, school absenteeism, cumulative cancer risk, drug compliance issues, and psychosocial issues. With that, I'd like to thank Dr. Bhupender for the kind introduction, Dr. Ashe, and all the IAP and GAPU members, and Dr. Sushil. Thank you very much.
Thank you very much. And I would like to now thank Professor Sama for his wonderful talk, comprehensive. You covered so much in that and very well informed. So thank you very much. Can we thank both of our speakers in the usual way?
Thank you.
And now it's my privilege to ask Dr. Nida Mirza to start the question and answer session, and I'll be joining in as well. Okay, thank you. So if you could go, do you want to start or shall I? Can you unmute yourself?
I'm unmute. Yeah,
okay.
There are only 2 questions, I think. So first,
I'll ask the questions. Actually, it's fine.
So there is a question for Dr. Okay, so there is a question for Dr. Sharma. Why severe growth retardation is an indication for surgery, sir?
Oh, yeah. So severe growth retardation in isolation is not an indication for surgery, but if you have severe growth retardation with poor response to your immunosuppressive agents, and they've defined severe growth retardation as, can't remember offhand, but it's near -3 or -4 standard deviation. So you have to be really, really short. So that means you have to have a huge amount of disease. And in this sort of a condition where you have nothing left, then you may have to just chop off the bowel.
There is perhaps an exception. We found that if they had restricted ileal disease at a certain age, when growth is fundamental, it's only that age when they're having their growth spurt, and it's a small area in the ileum, and the rest of it is all clear. They do very well because they tolerate the surgery and they're not losing very much of their bowel. That's the one time it's worthwhile considering. Otherwise, you can't take all of the Crohn's disease out. So it's best to keep the...
So Crohn's disease, you try and avoid as much as surgery as possible because it's just going to come back again and again.
Yeah. Anything else?
That's something I wanted to say. Yes, ileal restricted disease surgery is beneficial, but the recurrence rate, like Dr. Sarma said, is extremely high. So people used to think that surgery is the end point, but it should not be a substitute for taking patients off medical therapy completely. Recurrence. Yeah.
I agree with you, but actually, I think there's a big difference on how IBD in children is managed in America and in Europe. Big difference.
And in India.
Absolutely.
But in the UK, I'm sure we don't have a problem with the money. We can afford infliximab, etc. But for mild to moderate disease, we tend to use the elemental feed for Crohn's disease. And then we do use steroids with the azathioprine. I think you might have scared everybody off the azathioprine, but actually it's probably maligned because it suited the drug companies to say all of that was due to azathioprine, but in fact, it might have been a combination of the biologics with azathioprine. So we do use it, but we do levels. We're actually doing azathioprine levels and keeping them. So it's important that you're able to do levels. And that's
the levels are important, and the 6-MMP levels also are important. And absolutely, this is a medication that changed our lives completely from 1980 to almost till and even today, many patients can't afford our biologics at all. But at the same time, if it was available, irrespective of cost, it is the way to go. But the cost is phenomenal. The burden on the family is unreal. And I don't disagree with Dr. Bhupinder Sandhu, where I think the jury is still out. We need more. We need 1,200 patients who have never seen 6-MP. And then if we don't have any malignant side effects, only then can we say that this was due to 6-MP rather than blaming it all on 6-MP.
Actually, in the European group where we've donated, because I was found a member of the Porter group, and the European group have got data on lots. We've contributed our patients for the last 20 years, really, since we did the first study. And I think people confuse adult data with the children data as well, because some of your data was on adults, and it's really important we look at the two separately. And I think we, within the British Society, are reasonably okay with using it, but monitoring the levels and stopping, because there will be a small number who have a reaction straight away. They get pancreatitis and things, so it's about 10%. But in America, it's pretty well written off, and we think partly a bit of a pharmaceutical influence, but that's
I wish I could disagree with you, but I don't. There are a lot of studies are coming, like from, without naming names, from the city, that are just, the pharmaceutical companies are very, very powerful. And I think a balance needs to be maintained, and global data needs to be looked at. And I'm not disagreeing at that point. And, however, if I had my own child with this, and if I had a choice, and if I could afford it, I'm not sure. I definitely 20 years ago used to accept a not 100% therapeutic response as to be okay. I had patients who I would say, okay, you're going to school every day. You're stooling 26 times a day when you come back. It's acceptable, live with it. I think those things have improved significantly.
I think you were absolutely right when you said we need to know more about the phenotypes. We actually differentiate a lot from somebody who's got minimal symptoms. We picked them up because they weren't growing or the weight was not quite right. We treat those and the moderate ones differently. If it's severe disease, no doubt, because in the UK we can use biologics without any problems, but we don't rush for them. So the mild disease, we would use either nutritional therapy or steroids with azathioprine, and we start the steroids.
I stated that none of my talk was about mild to early moderate disease. Absolutely not. That's
severe disease. I agree with you.
Yeah.
Okay. Any other questions?
No further questions have been posted.
One more question is there. I think Dr. Sharma only. What is the average observed outcome of Crohn's disease or tuberculosis put on empiric ATT in India or globally?
Lovely question. This is, no offense, but the eco-explicant guidelines, they're meant for developed countries. They're not meant for the developing countries such as India. They don't talk about tuberculosis. 30% of our Crohn's disease have overlap with tuberculosis, and this is not my data. This is data from adults as well, from Dr. Govind Makharia's group in AIMS as well. And you may be wrong in 30% of the cases. So when you are in doubt, you have to give a trial of anti-tubercular therapy for at least 3 months. So you're going to actually delay the diagnosis of Crohn's. And you end up finally saying, oh, it's not worked, tuberculosis, the therapy has not worked. And this is just Crohn's from the very beginning. But they may look exactly similar, and our experience is 30%. And this is not something that is covered by any of the guidelines, sorry to say, from the developed countries.
Well, that's really helpful. Any other things specific to India? Because I mean, the States, other than they go for the they hire up pharmaceuticals more often than the Europeans do. Any other differences between?
Yeah.
we
The very early onset IBD, I didn't cover because it's a bit too much to cover. But that as well in India, we've had situations where people have diagnosed very early onset IBD, but it's turned out to be HIV. So yeah, so we've had this situation as well. So we've got patients that have been referred for very early onset IBD, and the first ELISA test for HIV came out to be negative. But when we repeated with the Western blot, it has turned out to be positive. So there are some nuances which we have in developing countries, which we must be alert, and that's it.
But are you able to look for the genetic markers? Because those are sometimes helpful. Yeah.
Yes. So from 2017 onwards, we've been offering clinical exome and whole exome sequencing, but the yield of that is sadly only 40%. I don't know what is it at your place, but we can only yield in 40%, and a small proportion of that genetic problems actually end up with hematopoietic stem cell transplant. So most of our patients who are very early onset IBD, they struggle with the anti-TNF and surgeries. Very poor quality of life.
Well, thank you very much. Anything else? Either of you?
They were asking about
question
role
for
of
Dr.
diet.
Sorry?
One more
Yes,
question for India specifically.
Yeah.
How can the progression be controlled with only diet and ASA than with biologicals? As in India, it is not affordable for most of the patients.
Yeah. So we've used diet in India. It really doesn't work. Somehow we end up putting all our patients on immunosuppression. So even if you use an exclusive enteral, the problem with India is your awareness and probably the level of literacy. So they're not going to follow the exclusive enteral nutrition as in how you prescribe it. So they're going to combine everything, and finally you realize that the exclusive enteral nutrition didn't really work. So most of our patients, 90% of our patients would have received corticosteroids. So exclusive enteral nutrition in India, though you would want it to work, and ideally it should, but a very small proportion actually benefit from the same.
Whereas in the UK, some of the parents will insist they rather have the enteral nutrition as a first trial. And kids go to school with a bag, so they can have a feed. It depends on motivation, but it is hard, and it's very hard to do it the second time around.
Yeah.
And we had.
Sorry, go ahead.
But it prevents, in our data, which was quite a large study, it prevented them having steroids for a couple of years. The second time around, a bigger percentage don't want to, because it's quite hard, not to eat anything else. And mixed feeding we know doesn't work. So if they're having ordinary food as well as the elemental feeding, it just doesn't work. So it is hard. So it's choosing the right.
So are you using the polymeric diet, or are you using the?
We use both, although my early studies were in elemental, and we used to have a sort of 92% rate, because I saw it all personally myself and everything.
So the elemental diet in India, again, it's quite unaffordable. So the polymeric diet is much cheaper.
Yeah. The polymeric diet figures are pretty well equivalent. Perhaps the elemental is much better, and most of my colleagues use polymeric. But we start the azathioprine right at the beginning now, because you don't wait for them to relapse. And the same with if they've had a earlier resection for growth failure, we keep them on the azathioprine. We know it's going to come back, so you don't take them off of a suppressant. Anyway,
Dr. Sandhu, you said are you using an NG or are you using a PEG tube when you are using it round the clock, or in school, or during work hours?
We give them a choice, and it depends. I mean, some kids are really, they don't mind the tube at all, but generally we try not to. We try and get them to drink over the day. We have a chat with the school nurse who will help them at school. If they're missing school, then that's a failure. You don't want them to be doing it. So they have to be a certain family with certain sort of children who tolerate, but who tells them and how they tell them makes a difference.
Makes a huge difference. And
Yeah.
sometimes we have used, which is not often, is nocturnal feeds, overnight feeds, so that they have the freedom. But again, you need an extremely
hungry during the
motivated
day.
family that is willing to place an NG on a daily basis, even though they are very thin 8 French tubes. But it's a very special family who will do that on a daily basis. Yeah.
But actually, most of our kids do drink it. But as I said, who helps them? And we have a psychologist involved as well. How they perceive it. And we always tell them it was actually accidentally discovered as a feed for the it was made for the astronauts, you know, that the elemental feed. I don't know whether all of you know that. And it was somebody who knew somebody who worked at the Space Center in Houston, who said, well, I can't, you know, I've run out of veins for this patient who's on TPN. Is there anything we could use? He said, oh, we've got this feed for the astronauts. And he gave him the feed, and that patient happened to have Crohn's disease, and the Crohn's disease cleared. So that's how it was accidentally discovered. And all the kids like the fact that they're having food similar to the astronauts' food, and that psychologically makes a difference. And in fact, our local television did a thing on it, but anyway. But we could chat forever. This has been a very interesting session, and I'm going to call upon Dr. Mirza to make a few closing remarks. And thank you so much to everybody. Dr. Mirza.
Yeah, thank you everyone for giving this wonderful presentation, specifically Dr. Moinek and Dr. Anupama Chawla.
Yeah.
Thank you, everyone.
And
Lovely
thank you.
morning.
Thank you. Thank you.
Thank you to all the organizers and behind the scene people, the IT team,
Absolutely.
and the BAPIO and the Indian Academy of Pediatrics team, leadership as well as the workers. So thank you all very much for making
Dr.
it.
Jane who responds within minutes.
Yes, wonderful. Very enjoyable event. I've really enjoyed it. So thank you so much.
Thank you, Dr. Sushil. Very kind of you.
My pleasure. Thank you.
Bye-bye.
Bye-bye.
Dr. Sandhu, Dr.
Bye.
Chawla. Bye.
Bye-bye.
Bye.
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 Bye. Hopefully bump into you again sometime, perhaps at the next BAPIO meeting in India.
That'll be lovely.
Thanks.
Bye, everyone. Bye. Bye.